Do you have your EKGs?
Can I just say, when I was watching the video, and I wanted to comment on your tone, and usually once they get something
No,
weird,
it's not.
no, it's not. Really? I don't think you would. And then I just wanted to compliment.
Thank you. That was a thinner, less fat carrot.
I really do not get
And before all my work,
Whenever you go pick up your order.
It's been almost 10 years since I made it.
well, yeah, I did.
No, now.
Still do. Are you ready?
Okay.
Yeah.
I am too. Okay. I just want you to know, I didn't forget. Me neither. I got everything ready.
It's my Saturday.
Are we ready?
Ready.
Ready, set, go. Everyone's still on spring break because most people have spring break this week or next week. We're pretty much the only campus that had spring break last week. It's ridiculous.
It was great seeing all the posts on Instagram, like, oh, going on spring break. I'm like, oh, yeah.
Yeah, everyone is either this week or next week. I never get a spring break because all my kids, I have always had different spring breaks. All my kids, all two, have always had 2 different spring breaks. And my honey has a different spring break, but he works from home. So I said, do you even know when your official spring break is? He said, I'm not really sure. I think it might be this week. I'm not really sure. What difference does it make? I said, good point. Well, we need to actually start analyzing our EKGs more this week to get you ready for your EKG test next week. Up on the screen, you're seeing 3 different profiles of the same cardiac cycle, the same set of events happening in someone's heart. Do these pictures look the same to you? No, they're not identical. And yet they're all reporting on the same event. It's sort of like our own country at this point, right? It could be the same event and we can get very different reports of it. A lot of fake news. So we need to entertain this concept of different perspectives of the same event. What is the same event I'm referring to? Electrical events that are happening in someone's heart. That's what I'm referring to. It doesn't look like I have much to lecture on, but this PowerPoint is actually 70 plus slides if you look at the long time out. See, you just said that you missed me, and now instantly you went, yeah, I know. You drone on and on and on. Most of the slides are meant to be played as a, quote, movie, which is why I had multiple versions of this PowerPoint online, short version, student version, etc. You not last week, 2 weeks ago, did your EKGs or ECGs. What's the difference between ECG and EKG? There's no difference. It's just German spelling versus American spelling of cardio. and the whole idea, also the idea of if you are radioing in an ambulance where it's noisy and you say ECG of the patient reads blah, 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 that can be misinterpreted as EEG, which is where it's a different kind of reading. So in order to get rid of not hearing things correctly, we say EKG. It's a hard sound. That's why we use it. The ECG is the same reference. You also learned from 2 weeks ago that There's a difference between electrocardiogram and electrocardiograph. One is the actual picture and one is the machine that is giving you the picture of these electrical events in your patient. The electrocardiograph is the machine. The electrocardiogram is the picture that the machine gives you. And what are the advantages of doing an EKG in a patient? Number one, it's not invasive. If we go back to the Hodgkin and Huxley experiments, we know that Hodgkin and Huxley took electrodes and pierced those electrodes, a stimulating electrode and 3 recording electrodes, into an axon, a giant squid axon. 2 weeks ago, you didn't pierce electrodes into your schoolmates' hearts. We put electrodes on the surface, so it's non-invasive. And because you're aqueous sacs of solution, any electrical events that are happening inside actually gets transferred to the surface of your body. And we can manipulate that. We can use electrodes on the surface of the body to detect these electrical events. There's a rub with that, though. There is a rub. A unit ago, you learned about action potentials. And you learned that the inside of all of your cells is negatively charged. You learned that. And you learned during depolarization that the inside of the cell became less negative, more positive. You learned that. So here's the rub. Because we are now putting electrodes on the surface of the body, we have to change perspective, right? That's the theme of this lecture today, perspective. We now need to think about the outside of the cell. That's our perspective. Why? We put the electrodes on the outside of the cell, on the outside of the human body. Think of that as a cell. Thanks to this perspective, we now can detect a myriad of issues in someone's heart without opening up their thorax to get a visual. We can get a visual in a non-invasive way. We can detect electrolyte disorders. We can detect if someone is having a myocardial infarction. We can even figure out if someone is having signal conductions. Do you know that there's a difference between a heart attack, cardiac arrest, and heart failure? Those things are not synonymous. Do you know the difference between them? A lot of people don't, and it's okay to say no. What were you going to say? Were you just...
Oh, then I kind of know the difference. You
kind of do. So heart failure refers to the ventricles failing to act as a pump. You can think of it as flabby muscle, right? Flabby muscle. And we will talk about cardiac disorders, if not this week, next week. We will talk about pathophysiology of the cardiovascular system. So heart failure refers to the ventricles failing as a muscle. They're flabby. They are not well formed. They are not contracting well. Cardiac arrest refers to a conduction problem. You were just starting to learn about specialized and contractile cells 2 weeks ago. We're going to finish that this week. Cardiac arrest refers to a problem with spreading the action potential through the heart. Or the action potential is not being initiated in the place where it's supposed to be. You don't have syncytium. And that was a word that we started to talk about, coordination. A heart attack / Myocardial infarction, those two are synonymous. That refers to a problem with ischemia, a problem with blood flow through the coronary arteries, a problem with serving nutrients like glucose, oxygen, and picking up waste products, including CO2. So a myocardial infarction / heart attack refers to ischemia. We're not getting blood delivery to the actual heart tissue for proper functioning. All three terms are very much interchanged in our society, and yet they mean very different things to us clinically. All right, so this theme for this lecture is all about perspective. Perspective. I need to teach you some physics. I need to teach you some words like vector. And what's a recording vector? And what's a cardiac vector? And what is this term lead meaning? A lead is a fancy way of saying vector because in a clinical setting, most nurses and doctors would choose not to talk about vectors because that's scary physics talk, right? But a lead is really synonymous with vector for us in this class. On the screen, you're seeing 4 different vectors. What is a vector? It's an arrow. That's it. It's an arrow. Arrows have an arrowhead, and they have a tail. Do we all know the difference? This is the anatomical review of an arrow. It's been a while. Arrowhead and tail. Okay, there are some rules that we need to know in vector analysis. And look, I can take all the physics behind this and make it disappear. I can teach you vector analysis in two different ways. I can either do it properly, where the physicists downstairs would say, "Good job, Kara, there's a reason why we hired you here." Or I could say, "It's good enough if you know it this way." Some of you will appreciate the Sister Mary Kara way, where it's proper. And the rest of you are going to appreciate it when it's 2 middle fingers up and it's good enough. You get to choose which way you want to master vector analysis. You choose one of the 2 ways. I will demonstrate both. A few of you will say, "No, I need the Sister Mary Kara way. It speaks my language." Most of you will say, "Yeah, I'm going to go with the it's good enough." It's good enough. What do arrows tell us? They tell us direction. But if they're drawn in different sizes, they also tell us magnitude. If anyone here loves the movie Despicable Me.
Yes, that's what I've been thinking about, vector.
Yes.
Okay, sorry.
So Vector, the antagonist in this cartoon, he was trying to tout him, "I am Vector," and he was trying to describe what a vector was. "I have direction and magnitude," he said. And it was lost on everyone around him, like, "Yeah, what? And to me, it was, "Yeah, you are quite sinister. You do show us direction and magnitude, and vector analysis most of the time is very scary to a lot of people." So it was a perfect antagonistic character for that film.
Wow.
Yeah. Yeah. Scary. A very scary movie. Very scary. Frightening. Terrifying. I encourage you to watch it. I will drop everything just to watch Despicable Me at any point in the movie. At any point. It's awesome. How are we going to use vector analysis to help us appreciate EKGs? First, Vectors show us direction and magnitude. The bigger the arrow, the more current. All right, so we're going back to Unit 2, where we were appreciating Ohm's law. Current is a flow of charge. The bigger the arrow, the more flow of charge. Many of you 2 weeks ago brought your EKGs up to me saying, am I okay? Because my QRS is not as big as her QRS. And I said to a few of you, and you look very different to me externally. And you all went back to your seats going, okay. So the amount of deflection of the pen refers to the amount of current moving. And we will analyze how much current is actually moving in your EKGs. Your EKGs have a graph taper associated with them. And you learned that when we look at the marks horizontally, it represented a unit of time. But what about the marks vertically? That represents an amount of current moving. For every 1 millimeter in vertical distance, it reflects 0.1 millivolts. We can actually measure the amount of current going through your heart at different points in time by measuring how much the pen deflects up or down in millimeters, knowing that for every millimeter that we measure, it reflects 0.1 millivolts. Direction and magnitude. And again, this vector analysis, well, when we look at the way that the pen goes up or down, it really represents direction. And that's what I have to teach you today. How does the pen going up or down actually refer to the direction of current going through your patient's heart? That's my job. If I teach it to you correctly, you won't have to memorize EKGs. If you take an EKG class, you will have to memorize picture after picture after picture. Right bundle branch block, left bundle branch block. All sorts of different syndromes. No, actually, if I teach it to you correctly, if you know the fundamentals, there is no picture someone can show to you where you can't say to yourself, aha, I know why the pen went up. I know why the pen went down. I know why the pen returned to baseline. No one can shake you if you know the physics behind the machinery. And ever since day one, I've been begging you to know what clinical tests can show you and what they can't. And I begged you to know how they're done. If you know those things, there's nothing future instructors can throw at you where it'll shake you. You will have confidence. You will be able to say, game on. I know how this test is run. I know its weaknesses. I know its strengths. I know what it can tell me and what it can't. And that's very powerful. Let's start. Let's go back to what we know. Let's start with something that we already know. We already know that all of our cells are negatively charged inside. We know that. Can you tell me the 3 biggest reasons why?
Leak channels.
Potassium leak channels. Negatively charged proteins due to our pH.
ATPase.
And the sodium potassium ATPase. Those aren't the only 3 reasons why, but the biggest 3. Okay, we also know from Unit 2 that when the inside of the cell depolarizes, that means the inside of the cell becomes less negative, more positive. Agreed? Okay. Change your perspective. Change your perspective. Instead of telling me what's happening on the inside of the cell, tell me what's happening on the outside of the cell. If at rest the inside of the cell is negative, then what is the outside of the cell? Good. If during depolarization the inside of the cell is becoming less negative, more positive, then what's happening to the outside? Becoming more negative. If during repolarization the inside of the cell is getting back toward negative, then what's happening to the outside? It's becoming positive. I need you for this unit to take the perspective of the outside of the cell. Why? We put the electrodes outside of the cell. EKGs are not invasive. Because we are not doing the Hodgkin and Huxley experiments where we pierce the electrodes into the cell, we have to change our perspective. What is happening to the outside of the cell? I need you to know during rest and repol, the outside of the cell is positive. You have to know that. Otherwise, vector analysis will be lost on you. That's one of your first rules you have to know. Rest and repol, the outside of the cell is positive. Okay? Okay. During depolarization, the outside of the cell is negative. Depolarization. Our perspective during depolarization, the outside of the cell is having a spread of negative surface charge. Repolarization, we see the positive surface charge come back. Vectors, their arrowheads always point to positive surface charge. That's a rule. Let me say it again. I just told you we have to change our perspective. We have to entertain what's happening to the charge on the outside of the cell. Lecture Unit 2 was all about the charge inside the cell. Now we're outside. We're still talking about the same electrical events. We're just taking a different perspective. Vectors, arrows, always point to positive surface charge. And when will the cardiac cells have positive surface charge? During rest and repol. Think of the two R's. Rest and repol. Repolarization. You hooked up these wires to each other. In a clinical setting, these wires are called leads. They're really vectors. That's what they really are. They give direction. They can record the direction of the electrical current going through a patient's heart, and they can also give you a reporting of magnitude. Direction and magnitude. Magnitude of the amount of current going through your patient's heart. Direction and magnitude are important to us. We got to figure out what's happening in our patient's heart, and the direction of the current should go in a certain way, and that direction can fail, and I'll explain how probably next week is when I'll get to it. The amount of current can also be an issue. If there isn't enough electrical current, then tell me, what do you think is going to happen to the mechanical events? Electrical events must precede mechanical. So if our electrical events are failing in any way, not going in the right direction, not giving enough electrical current, then what do you think is going to happen to the mechanical event? It's going to be weaken or fail. Of course it will. These electrical events are important. Last week, I started to introduce the direction of these leads, these vectors. Do you have your EKG printouts? Can you just get one out and put it on your desk? For both classes, I introduced this paper. On the left side, you had a recording of lead 1, 2, and 3. I said, look at the recording for lead 1. You all found it at the top left of your paper. I said, look across until you get to a vertical like dashed line. Do you see that? A vertical dash line. And I said to the right of that vertical dash line was a lead called AVR. Correct? And I said that vertical dash line tells you that the machine stopped using a recording from lead 1 and went to a different camera. Remember I referenced camera, right? And I talked about watching a sporting event and how they would have replays and they would get a different camera perspective. Think of these leads, these vectors, as cameras. They're giving you different perspective of the same event, just like when we watch a sporting event. Replays, different camera angle. Makes a huge difference when referees have to review a play. Agreed? It was the same event, different perspective, camera angles. Lead 2 was another perspective, a different vector's view, a different camera, if you will. And I started to introduce to you the directionality of these leads, these vectors, these cameras. Vectors have orientation. Arrowheads of vectors always point to positive. So your responsibility is to know the orientation of your leads, of your vectors, the cameras you place on your patient's body. These leads are stationary. They don't move. It's as if the camera is fixed in place. Anything that happens in my line of sight, I can record. But if something happens over here, I hope a different camera angle captures that. Okay? What are the 6 leads I need you to know for next week's test? Lead 1, 2, 3, AVR, AVL, AVF. We place electrodes on our patient. We connect these wires that we call leads. And when we connect them, we are really creating a vector, an arrow. That's what we're doing. And arrowheads always point to positive. So lead 1. Lead 1. You have your patient. Lead 1 is negative on the right wrist, positive on the left. So what is the direction of lead 1? Straight across your patient's chest. Straight across, from right to left. Now, anatomy was a prereq. Here's your patient's heart, which doesn't really look like that. Lead 1, your patient's right to left. This is your patient facing you. That's lead 1. Lead 2, shown up here on the board. Lead 2, your patient's right arm was held negative. Ankles positive. So lead 2 faces or points down and to the left of your patient. Down and to the left. Let's just focus on lead 2 for a moment. Let's just take lead 2, camera angle 2, its perspective for just a moment to learn about vector analysis. Here are rules that you need for vector analysis. Number 1, our perspective is surface charge. When we talk about resting membrane potential, depolarization and repolarization, instead of telling me what's happening to the charge inside the cell, you now need to tell me what's happening to the outside. Number 1. At rest, the outside of the cell is more positive. During depolarization, the outside of the cell becomes negative. During repolarization, the outside of the cell is becoming positive again. Next rule, vectors, arrows, always point to positive surface charge. Always. Next rule, we always compare a stationary vector to the vectors that are moving. I'll say that a different way. A camera might be fixed in place. If you think about some wildlife cameras, they set them out on trees, right? Most notably, we're worried about the pumas in the Los Angeles area trying to cross the freeway, and we're worried about the inbreeding. If any of you read the paper, they have, look at the confusion. Look at the confusion. Does anybody know what I'm talking about right now with the cameras and the mountain lions and the problems of them being trapped in Los Angeles and they can't cross the freeway to find new mates, and so they're inbreeding? No?
Yes.
Anyway, wildlife conservationists, they love to set up cameras, but no one's staying there to man the camera. It's fixed in place. And every once in a while we get giddy because some sort of animal happens to cross in the path of the camera. I want you to think of the leads you attach to your patients as cameras that are fixed in place. They're not moving. We have to compare the perspective of that stationary camera to a moving object. Not the mountain lion, but the direction of current flowing through your patient's heart. Think of that as the moving animal. The current is flowing through the patient's heart. It's moving from right to left, top to bottom, but also posterior to anterior. It's constantly moving. We're trying to capture the movement of that moving animal by looking at different camera perspectives. When we are trying to interpret a moving vector, electrical current that's moving right to left, top to bottom, posterior to anterior, to a stationary vector that we place on our patient, here's another rule. If the camera perspective, if the lead direction points in the same direction as the moving animal, the cardiac vector, the moving current through your patient's heart, if they go in the same direction, arrowheads pointing in the same direction, we say they are parallel. And the rule is the pen must go up. If they move in an the moving vector, cardiac vector, points or is migrating in a different direction than the stationary camera, your lead on your patient, if they are anti-parallel, the pen must deflect down. If they are perpendicular, the pen must go back to baseline. If there is no current, no movement of electrical activity going through your patient's heart, the pen also goes back to baseline. What do we hear in clinical shows where when a patient has no electrical activity in their heart, what do we hear them say? They're flatlining. It's because the pen is obeying a rule. It's going back to baseline. What is baseline? When the pen is going straight across the paper. That's the baseline. That's the starting point. The pen goes up, it goes up. Goes down, it goes down. But anytime it goes back to this flat line area, that's baseline. That's its starting point. If your patient has no electrical activity, pen doesn't go up or down. There's no animal moving in front of the camera. There's nothing to report. I go back to where my steady point is. Flat line, baseline. Those are your rules. If the animal, the moving heart vector, cardiac vector, is pointed in the same direction as your stationary camera, your lead, pen goes up. If they are anti-parallel, pen goes down. If there is no current, back to baseline. If the vectors are perpendicular in any way, back to baseline. Those are the rules. There aren't many of them. I argue these rules are really easier than most card games you might play. Uno has more rules. Cribbage has more rules than vector analysis. King's Corner. No one knows what cribbage is?
Yeah, what's cribbage?
Oh. Does anybody know how to play cribbage in here? Thank you.
Is it a card game?
It is a card game.
Well,
It's
that was
a.
the theme. They were all hard.
That's true. It's Monday morning.
I know, and we're mushy brain.
It's your shitty American roll.
Cribbage is a great way to teach kids how to add. Yeah, it really is.
How do you spell it?
Cribbage.
I knew how to spell it.
Well, I didn't. I was asking.
I like it. We play it a lot in our house. Fewer rules in vector analysis than there are in most card games. Different perspectives that you hooked up to your patient. Lead one, right to left, gives us the perspective of current moving from right to left. Lead two points right from the right arm down to the left. Down to the left gives us perspective of current moving from top, superior, to bottom, inferior. Lead three, negative on your patient's left wrist, positive on the ankles. Again, gives us perspective of current moving from top to bottom, just in a different orientation, a different oblique view than lead two. Correct? Lead one, lead two, lead three. We'll add to that AVR, AVL, and AVF in a moment. Let's use lead two, first of all, to appreciate how to use vector analysis to figure out why a pen will go up or down. Your job, lead two, what is its direction? From right to left top to bottom, correct? It points down and to the left. Let's go through our cardiac cycle. All of you went through the first part of the cardiac cycle lecture. We started with diastasis. Remember this? All the chambers of the heart relaxed. What is happening? Blood is returning to both the atria and is pouring straight down into the ventricles. As the blood returns, it opens the trapdoors that we refer to as the AV valves. There's a lot of blood sloshing around, and we hear heart sound 3. This is passive filling of the ventricles. Then you heard me say 2 weeks ago that the SA node suddenly will reach threshold. Remember what that meant? And they reach threshold first, the SA node. And where is it found? In the top of the right atrium. That's where the SA node is found. If the electrical event starts at the top of the right atrium, how will that electrical current move from cell to cell through the intercalated discs? That was a unique anatomical structure in cardiac muscle cells that allow electrical currents started in one place to travel to another through the cytoplasm. And 2 weeks ago, I told you about some pretty sick experiments that I did as a graduate student. Do you remember? Mincing up the little fetal hearts. And some of the heart cells would ball up and then relax. And others were living, but they didn't do anything until they made their connections. Do you remember this? It was a long time ago. So if the SA node depolarizes first, describe how the current would move through that person's heart. If it starts here, what direction will it go? Can you visualize that it would travel to the left atrium, but also down through the heart, from the atria towards the ventricles? If I had to give just one vector to describe this right to left, top to bottom, if I had to merge these two red vectors that I've drawn on the board, do you agree with this yellow one that I've drawn on the screen? Overall, the moving animal is going from top to bottom, right to left, down and to the left. Can you all see that? Do you all agree? Okay. Well, if this is my moving animal, and this is my stationary camera, and I go back and I think about the rules of vector analysis that I just quickly told you about, I said if two vectors are parallel, pointing in the same direction, the pen must do what? Go up. If they're anti-parallel, the pen must do what? Go down. If they're perpendicular, what must the pen do? Baseline, or no current, no animal moving. Baseline. Okay, so compare. Here's your moving animal. Here's your stationary camera. Tell me what the pen will do. Do those look parallel to you? So my geometry training, and I've been through geometry 3 times now, tells me if I continue this tail of this yellow vector, I will intersect this leaf. This to me tells me they are not parallel. If I were just learning this today, like most of you are, I'd be really confused right now and say, well, what good was it learning those rules. I knew it, Kara. Just like most card games, there's always a cheater. There's someone that knows more rules or how to, it's like being a lawyer. How do I obey the rules but still interpret them differently to bend them to my will? What's a poor student to do? Okay. Sister Mary, Kara, proper way of vector analysis. You ready? All I did from the previous picture to this one, all I did was just realign these vectors so they touched. That's all I did. Watch, I'll show you. I just made them touch. That's all. That's all. Just to prove to you they're not perfectly parallel. They're not anti-parallel. They're not perpendicular. They're not. If you were to travel from Orange County Airport to LaGuardia Airport, does everyone know where that is?
Yes,
New York. Look at the confusion. No, I'm in science, not geography. If your body was a map of the United States, point to me where you would be for Orange County. Look at the confusion.
Oh, we're using your body?
No, your body.
Oh,
Like, is it this way, or like, is it going this way, or is it going this way?
Right knee.
Okay.
I mean, this could be Florida very easily.
No.
Florida's your left toe.
Thank you. Florida is probably your scrotal sac. Maine would be this way.
So you're right. Your left elbow.
Orange County somewhere over here. New York somewhere over here. Anyone playing nicely with me on a Monday morning after spring break? Look at the confusion. Now, if you were to take a direct flight from Orange County to New York on a map, I should say, showing the United States, what would that look like if you drew a vector to describe that? Wouldn't it be that way? Okay, but you're too cheap or you don't have enough money to buy a direct flight. Could you, as an option, take two indirect flights? Two flights that would get you there indirectly. Couldn't you go up to, say, Seattle? Could you? Mm-hmm. And then cut over? Could you? Could you? Okay. Here's my direct flight. My current is flowing down and to the left. That's my direct flight. When we were flying to New York, we were going up and to the left in our example. Our current, our direct flight in our heart, down and to the left. Can I draw two connecting flights to get to the same destination, is my question to you. Yeah, could I go this way and then down? Two connecting flights, isn't that a possibility? All right, so let me draw in my connecting flights. What does this connector represent? It's a perpendicular bisector. Scary terms meant to bully and make students be submissive. Don't let that happen to you. Here is my stationary camera. Okay? Can't I draw a line straight through it that is a perfect perpendicular line to it? That's all I did. When I draw a perpendicular bisector, here's what I'm doing to a vector, a recording vector. a lead. Here's what I'm doing. I'm dividing it into a number line. This is not new. This is not new. Draw for me on your paper a traditional X and Y axis. How did you know how to do that? Instantly, all of you are like, finally, something I can do on a Monday morning. How did you know what to do? I said, draw me a traditional X and Y axis. What did you draw or visualize in your head? Where's the X? Where's the Y? Why did I draw them that way? Have you ever drawn your X and Y's that way? No, you didn't. No, you didn't. You drew them like that. Where's the origin? What does that mean? What are the coordinates of the origin? Nicely done. And what's the protocol? X, Y. Good. Why did I draw my X and Y like that and you didn't?
Number line keeps going.
Aren't all the digits to the left of this perpendicular bisector positive? Yes. Didn't I just tell you that all vectors point to positive? I did. What about isn't the X a perpendicular bisector to Y? So aren't all the digits above the X perpendicular bisector positive? They are. When I drew a perpendicular bisector to this lead, this vector, this recording lead we call lead 2, I am dividing lead 2 into a number line. Anything from this point down and to the left has what sign associated to it? Positive. Anything behind it is negative. I've just turned it into a number line. It's no different than your X and Y's. It just has a slightly different tilt to it. This is not new. It's just presented to you in a different way. All right, I need my next connecting flight. I need to go from my perpendicular bisector to the same direction my direct flight went. So what is that going to look like? From here to here. Do you agree? That's my destination. I have to get to the final destination, the same destination as my animal that's moving. Do you agree with that? Ah, if I look at the two red lines now on the screen, what can you tell me about their directionality? They are parallel. They are most certainly parallel. And that's the proper way to use vector analysis. You draw your perpendicular bisector. You divide your lead, your recording camera, into a number line. Once you draw your perpendicular bisector, you make your connecting flight to the same destination. And it's that second connector that will either be parallel or anti-parallel. And here's my pen going up. You see that? My pen goes up. So those two are definitely parallel. Next thing. Well, that current spreads, and eventually that electrical event is over. It's over. the electrical event is ending in the atria, if the electrical current is dissipating, what should the pen do? It's going to go back toward baseline, isn't it? And that's what happens. The electrical event in the atria, it's over. The pen is going to go back down toward baseline. And it's going to stay there until the next electrical event occurs. During this time, as the atria are finishing their electrical events, and the pen is going back toward baseline, and then it's going to stay at baseline, we need to ask ourselves what mechanical event is now occurring in the atria after they've had their electrical event. They're going to contract. And it's during this time that we get the last 20% of blood being pushed into the ventricles. It's during this time that we get our top off. Remember that analogy for filling your gas tank? We're getting our top off. So that's what we need to be thinking about. When we see the pen going up, we need to say to ourselves, oh, the atria are having their depolarization, their electrical event. What mechanical event will ensue, will follow? The atria are going to contract. We're going to get our last remaining 20% of ventricular filling. What would I hear? I would hear another heart sound from that squishing of the extra blood into the ventricles. We would hear heart sound 4. All of these things should be going through our head as we see the pen go up, come back down, and hit baseline at this moment. What else would we be thinking of? Well, that electrical current is moving down and to the left, and eventually it's going to hit the AV node. The AV node cells are small. What do we know about small size cells and their kind of resistance to electrical flow? Do they give greater or less resistance? Big axons had less resistance than smaller. Small size cells in the heart, same concept. If AV nodal cells are small, then our resistance goes up. And that means the relaying of the electrical signal has now been dampened, slowed. Additionally, the AV nodal cells have few intercalated discs. So if we have fewer gap junctions to allow the current to move from one cell to the next, at this point, again, the relay, the velocity of this electrical event has been slowed. We have 2 exit doors. If I say all of you have to exit through that door, it's going to take us longer to evacuate this room than if we had both doors as an option. Agreed? Mm-hmm. Same concept for intercalated discs. Gap junctions, connectors from one cell to the next. Additionally, the heart has a skeleton, a fibrous skeleton. Fibrous material, collagen, is not a good conductor of electrical current. This is going to create another delay from the AV node down to the IV septum. We see a delay at the AV node to the IV septum because of the small size cells, fewer gap junctions, fibrous skeleton. The bundle of His is the part that connects the AV node to the IV septum. That is the fibrous skeleton part that's creating another delay. We see a delay at the AV node. We see a delay through the bundle of His trying to get through the fibrous skeleton. The electrical current is there, but it's not a huge amount of current. It's going through fibrous tissue, and our machines can't pick up on that. Not the machines that we traditionally use in a clinical setting. If the machine cannot detect current, then what should the pen do as a rule? Baseline. Our patient isn't dead. At this point, it's just because the amount of current has been slowed and it's so weak because it's going through this fibrous tissue. The machine is not sensitive enough to pick up on it. Not the ones that we traditionally use. The pen has to obey the rule. The machine does not detect the current. I must go back to baseline. Never fear. Eventually, the IV septum is going to get its electrical current. Now, let me draw on the board the specialized cells. Two weeks ago, I introduced the specialized cells and I showed you a little animation of electrical current going through the specialized cells, and I said to you all, everything you see here in yellow are specialized cells. It was the SA node to the AB node, so SA, AB, and there were also internodal pathways that you saw looping from the right atrium to the left. This was the bundle of His. And then we saw right and left bundle branches going through the IV septum. And then we saw Purkinje fibers going along the ventricular walls. Right bundle branch, left bundle branch. Purkinje fibers going through the right and left ventricular walls. This was not an accident. The way I drew the right bundle branch going slightly up before it curves down is a real anatomical feature. Some of you have right bundle branches that grew more in this arc than others. But it's a real anatomical finding in a lot of people. If you were a car driving down to the apex of the heart, and the bundle branches represent the roads you could take to get to the apex, which bundle branch is the most direct path? The left. If you took the right bundle branch to get to the apex, would you take more time to get there? You would. Okay. Let's take that concept and think about the depolarization. As the electrical current is moving through the bundle of His, it's now going to have to split and travel through both the left and right bundle branches. As these specialized cells, these bundle branches, depolarize, what surface charge will they have as they depolarize? Negative. Remember, our perspective is the outside for this unit. So let's draw that. negative, 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 negative. 1, 2, 3, 4, 5. I just drew 5 negative signs on the left bundle branch. Some of you are taking the right bundle branch to get to the apex. 1, 2, 3, 4, 5. You all said to me if you took the right bundle branch to the apex of the heart versus the left, you would be somewhat delayed. You'd be behind. Agreed? Okay. So if the left bundle branch is faster than the right, do you agree this side of the heart would still be positive compared to this side? The car is faster on this side, direct shot. Arrows always point to positive surface charge. The left side, faster to depolarize than the right, which means they're all the way down the IV septum. We have a vector that points slightly up and to the right to show that the right side of the IV septum is somewhat behind the left side. Here's my tiny little vector to represent that. It's a tiny little difference in surface charge, but it's there. Now I have a vector that points up and to the left, and look, just like the previous 2 slides, all I'm doing, I'm just picking this up, and I'm connecting it to my lead vector. That's all I did. Just picked it up, and I moved it to make them touch. I made them touch so I can draw my connecting flights. That's all I did. Here's my perpendicular bisector. We know what that is now. Here's my connecting flight. Now I can compare my recording lead to my connecting flight. And what position do they have relative to each other? Are they parallel? They're anti-parallel. And what should the pen do? It should go down. Pen started to go down. Now, if I want to use words to describe both of these cars trying to get to the apex of the heart, left car getting there faster, slightly ahead of the right car, but aren't they both going towards the apex? Overall, aren't they moving towards the apex of the heart, which has the direction of down and to the left? Isn't that how our apex of our heart points? So if I use those words, overall, the electrical current is moving down and to the left towards the apex. Why am I drawing an arrowhead down here? Arrowheads always point to positive surface charge. The apex of the heart will still be at rest, have a positive surface charge, when the IV septum is depolarizing, has a negative surface charge. The apex of the heart has to wait a while. If I compare the IV septum to the apex of the heart, the electrical current has to move from top to bottom. That means the cells there are waiting for their depolarization. They still have a positive surface charge. The top of the IV septum has already depolarized, already has negative surface charge at the top. Do I really need to use vector analysis to compare this vector to this one? Do you really need me to draw my perpendicular bisector and my connecting flight for those two? Or can you start to visualize that overall they're going in the same direction? Aren't they parallel enough for you to say to me, Kara, the pen should go up? If you can recognize that visually, congratulations, you're at the phase where you've got your two middle fingers up to vector analysis proper, and you're saying, I can eyeball this. I can eyeball this. It's a close approximation. My moving vector is now pretty much parallel with my stationary vector, and the pen should go up. Here's my pen spiking up. And why is it going up so much, do you think? There's a lot of electrical current going through the IV septum. Do you remember dissecting the sheep heart in anatomy and how thick the IV septum was? That's a lot of muscle tissue there. Of course there's going to be a lot of electrical current going through it. How much the pen swings up or down reflects the amount of current. Up, based on your recording lead, tells you we're going in the same direction. How much it goes up tells you the magnitude of the current. Vectors tell us direction and magnitude. Now this electrical current has to spread to the left ventricular wall through the Purkinje fibers, but also to the right. Purkinje fibers along the left ventricular wall and along the right. I have some current going this way and this way. I've got two different vectors, don't I, to point to that direction. Which side of the heart, when we're thinking about the ventricular walls, has the thickest ventricular wall? Left. And if you think of yourself sitting along these ventricular walls, waiting for that electrical event to come by you, like a parade coming by you, which side of the heart would you be waiting for that parade the longest before it came by you? The left, especially if you were sitting way out here towards the top of the ventricular chamber on the left side that has a thicker myocardium than this side. Because that current not only has to go around the apex to each wall, but it has to go through the entire thickness of the ventricular wall. So if you were waiting underneath the epicardium on the left side, the last muscular cell waiting for your electrical event to come to you, you'd be waiting the longest on the left side towards the base of the heart. You'd be waiting the longest. You'd be holding your positive surface charge the longest. And which way do arrows have to point to? Positive surface charge. And that's the reason why I drew one vector that best represents the fact that if you were the last myocardial cell on the ventricular wall, on the left side, closest to the epicardium, you'd be waiting the longest for your electrical event. You'd be waiting the longest. You'd be holding your positive surface charge the longest. And that's the way my vector has to point. How does it point? Up and to the left. Which way is lead 2 going? Down and to the left. Is this parallel? Is it perpendicular? No, it's not. Is it somewhat anti-parallel?
Yeah.
Can't we approximate that? So what should my pen do? Go down. Absolutely, it should go down. And that's what I've drawn. And if you need your proper vector analysis, look, all I did, I just moved it to make them touch. I drew my perpendicular bisector and I drew my connecting flight. My connecting flight is anti-parallel to my recording lead, therefore my pen should go down. Well, now we're going to have another electrical event. But before this next electrical event occurs, the current electrical events that we just described going through the IV septum and around the ventricular walls, that was depolarization. A mechanical event has to occur at this time. The mechanical event that is occurring is the ventricles start to contract. And 2 weeks ago, I used students' water bottles in our lab room to show that as the ventricles push on the blood inside, the blood would rise superiorly. Remember this? And it would push on the underside of the AV valves and close them. And before the ventricles generated enough pressure to open the semilunar valves, the blood inside would be reverberating around, sloshing around. All 4 valves were closed at this time, and we call this isovolumic contraction. When the ventricles generate enough pressure to open the semilunar valves, we would get ejection. Before ejection, when all 4 valves are closed, we would still hear a heart sound, and that was heart sound 1, where most of you, your anatomy professor said, heart sound 1 is from the closing of the AV valves. And I taught you 2 weeks ago, that was not a complete statement. Do you remember? It's not from the valves themselves slapping and making the sound. It's from the turbulent blood flow inside the chambers, having nowhere to go. When the ventricles finally open the semilunar valves, we get ejection. We get a stroke volume, and I taught you 2 weeks ago that's about 70 milliliters. Well, what's our next electrical event, Carrie? You said there's another one coming. Yeah, repolarization. The ventricles need to repolarize. That means go back to their resting membrane potential, or back toward it. And we forget that that is also an electrical event that will also lead to a mechanical event called relaxation. So how will this electrical repolarization occur? Well, I need you to act something out for me. And it's a really important enactment. So I want you to make sure that the items around you are clear. I need you to be able to get out of your desk and stand up and then sit back down. Make sure you're safe, but don't stand up yet. See, I'm going to get you moving and exercising. I should have warned you to wear your Tennico vest. The first enactment that I want you to do is pretend for a moment that we're back in the atria. Let's go back and visit their electrical events and what it would look like. Let's pretend that this side of the room is the SA node found in the top right atrium. Let's pretend that everyone on this side of the room represents the bottom of the left atrium. Our current has to move from where it begins, the SA node, to where it finishes in the atrium, the bottom part of the left atrial chamber. How does that current move? From right to left, top to bottom. Down and to the left is another way of saying that. Right to left, top to bottom, another way of saying that. Down and to the left. That current is going to move through all the cells of the atria in a coordinated fashion, syncytium. What would that look like to us in this classroom? Well, as the cells depolarize, they would lose their positive surface charge. Think of you all right now sitting as having positive surface charge. Right now, you're all at rest. Think of standing up as depolarization, getting negative surface charge. What would that look like if it rippled through our classroom in a coordinated event? Stand up, stand up, stand up, stand up. Oh, what mechanical event would occur in the atria? Last 20% top off, squishing the last little bit of blood into the ventricles. You all stood up first. What do you think you should do? Repolarize, 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 repolarize. Does that make sense? First to stand up, first to repolarize. Go back to rest, getting your positive surface charge in a coordinated fashion. Awesome. That's how the atria depolarize and repolarize. But what about the ventricles? If we think about ventricular depolarization, we've got a bit of a conundrum. We have to get the current through the fibrous skeleton. We have this left bundle branch and this right bundle branch that seems to take a detour. We then have to get through the left and right ventricular walls, the left being thicker. That means it's going to take longer for that current to get through the entire thickness. There's another issue though. Where is the exit hole that the blood must go through to leave the ventricle? Is it at the bottom? Because in the atria, it was in the bottom, wasn't it? The ventricles, it's in the ceiling. That's where the semilunar valves are found. So, if you think about it, when the ventricles contract, there are multiple phases to this mechanical event. Go ahead and use your own fingers if you want to. The apex of the ventricles, because the IV septum depolarizes before the ventricular walls, the apex of the heart is going to be pulled up. If the IV septum has its electrical event first, it's going to have its mechanical event first. Yeah, we didn't think of it this way, did we? So that means the apex of the heart is going to be pulled up. Think of this. When that happens, think of it as the blood's now being pushed up superiorly. What would that do to the pressure underneath the AV valves? Increase. It would increase, and wouldn't the AV valves close? Yes? The AV valves would close. But the apex is the only part that's being pulled or worked on at this point. The ventricular walls are still waiting for that parade to hit them. So at this time, the blood is being pulled up superiorly, the AV valves are being pushed closed, and the blood inside, there's no blood coming in or out, but it's sloshing around. It's making a sound. Heart sound 1. Finally, the electrical vent coming down the IV septum finally goes around the ventricular walls. What will the ventricular walls do as their mechanical vent? Squish! So if you use your own hands, IV septum pulled up, then ventricular walls, stroke volume. Stephanie.
So does that explain why the muscle tapers off towards like superiorly is because of that pulling up? Because they don't need that much force.
It's thicker along the ventricular wall, but how much do you need up here at the top? Not as much. But up, squish. Now, think about this. When we acted this out for the atria, you all depolarized and then repolarized. First up, first down. If that works the same way in the ventricles, what would that look like? First up, second up. If first up was first down, how would the blood be pushed if that happened? Would it be pushed out or down? Down. So in the ventricles, we're not going to have a first up, first down. Nope. We're going to have a first up, ventricular walls contract, stroke volume, relax, then the IV septum relaxes. First up is the last one. So if you all represent the top of the IV septum, and over here, you all now represent the top of the left ventricular wall, waiting the longest for your parade, what would that look like? Depolarize, 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 depolarize. What mechanical event is occurring? Blood is being pulled up superiorly and ejected. Well, now we need repolarization. Last up, first down. It's reverse in the ventricles. Who stood up the longest? The top of the IV septum. They have the longest lasting action potential. That should blow your mind. That there are cardiac cells in your heart that have different lengths for their action potentials. That's remarkable. You all stayed depolarized longer than the left ventricular wall. They had the shortest lasting action potential. That's remarkable. Vectors always point to what surface charge? Okay. This side of the room, IV septum, start to depolarize again. Depolarize, depolarize, stop! What surface charge do they have? Negative. We're switching our perspective. They're still at rest. What surface charge do they have? Positive. How should our vector point? To them. Where are they found? I said those students were where? The top of the left ventricular wall. That was our vector that I pointed this way. Okay, so now you all depolarize. Keep going. Keep going. Keep going. Now you all have negative surface charge. You all do. There is no directionality. Everyone's the same. All the ventricles negative charge right now. What should the pen do? Go back to baseline. There is no directionality to the pen. It's like we have no current. I have no difference in charge. We're all same. Now you repolarize. Positive surface charge, positive surface. Stop! You all still have what charge? What do they have? Do we have directionality? How does that look? Go ahead and sit down. How would that look? The vectors would point up, both left and right, towards the base of the ventricles. And that current would be coming back towards the apex. The apex would get its positive surface charge before the top of the IV septum. Before the top of the IV septum. Do you agree with my purple vector? Where was the apex in our classroom? Somewhere here. And they were all still standing. I said, stop, remember? Point to the positive surface charge. Apex gets to sit down and go back towards rest before the top of the IV septum. They stayed standing up the longest. So if I look at this repolarization event and use a vector to represent it, this is parallel to my recording lead. What should the pen do? Go up. Starting to go up. And then as all of the ventricles go back to their positive surface charge, there is now no discrepancy. All 4 chambers are now at rest. All electrical events are done. What should the pen do? Go back to baseline. And 2 weeks ago I said, if you are at most 2-year traditional schools for pre-nursing majors, I told you all I could have had this EKG lecture done in 20 minutes. I would have drawn this first bump is the P wave. It represents atrial depolarization. This downstroke is the Q, upstroke is the R, downstroke is the S, and I would have said to you all, it represents ventricular depolarization. Then the next bump, I would have said to you all, is the T wave, and it represents ventricular repolarization. And as I pointed to those things, I would have said, these are the electrical events. Please tell me what mechanical events would occur as a result. And we'd be done with it. PQ or ST, darling, adorable. I started this lecture with a picture of 3 recording leads, 1, 2, and 3. And I asked you all, do they look the same? And you all said, no. You all said no, they do not look identical. Good. Let me recreate for you what just happened in a span of like 15 slides. In orange, let this represent recording lead number 2. Does it ever change? Isn't it stationary? Stationary. I showed you the vector of atrial depolarization, the moving animal for atrial depolarization. What direction did it go? Didn't it go from right to left? Top to bottom? What's another way of saying that? Down and to the left. We acted that out. You all were the SA node. You all were the bottom of the left atrium. You depolarized. You repolarized. First up, first down for the atria. What is that cardiac vector? One vector to show down and to the left. I showed you that. And I showed you the proper vector analysis. I drew the perpendicular bisector. I drew the connecting flight. And are you at the point where you can say this is a close enough approximation? They're both going in the same direction. What should my pen do? Go up. Then I told you about depolarization through the ventricles. We have two sides to the IV septum. We have the direct car drive to the apex on the left side, but we have this anatomical detour on the right. They're both going towards the apex, but one side is slightly behind the other. And I said we have to recognize that. The right side is slightly behind the left. And I said that little vector points up and to the right. And I showed you the perpendicular bisector and the connecting vector to show you why the pen would go, in fact, down. Isn't that a close enough approximation in your mind to go, those are anti-parallel? So what will happen? The pen goes down. Then I said, but both cars are going towards the apex of the heart. The top of the IV septum depolarized first. The apex, the bottom of the IV septum, still is waiting for that parade. Positive surface charge, still sitting. I made you all start standing up and I said, stop. Is that a close enough approximation for you? What should the pen do? Go up. Then I said, which side of the ventricular walls would be waiting the longest? Who sat down the longest for ventricular depolarization? The top of the left ventricular wall. How does that vector point? Up and to the left. Isn't that a close enough approximation to your eye to say that's anti-parallel? So what should the pen do? Should go down. Then everyone was standing up. All negative surface charge. Was there any vector then? To the pen, that means no electrical event. What should it do? Go back to baseline. Then I had you act out repolarization of the ventricles. Did repolarization happen the same way in the ventricles as it did in the atria? Wasn't it backwards? Who had the shortest lasting action potential? Who waited the longest to stand up but then immediately sat down? Wasn't it them? So they sat down, you all sat down, positive surface charge back, and then around here I said, stop. They were still negative. You all were positive. Isn't that a vector now? So the apex of the ventricles repolarizes before the top of the IV septum. Is that parallel or anti-parallel? What should the pen do? Go up. And then I said all electrical events are over. All chambers are relaxed now. Pen should go back to baseline. Is it lost on you that when traditional schools teach this cute darling PQRST, when they show you that traditional drawing, you should understand at this point, we only get that drawing because of using lead 2. What would that drawing look like if someone strapped on lead 2 backwards? It'd be the mirror image going in the wrong direction downward, wouldn't it? Totally different perspective. The pen doesn't know if you've made a mistake. The pen only knows these are my vector rules. So if you see a totally funky PQRST with lead 2, you probably want to check your leads before you go screaming down the hall calling for the doctor. Just a suggestion. What if we used a different lead? What if we used a different lead? I'm erasing now lead 2. I'm keeping all of those cardiac vectors. In green, atrial depolarization. In blue, those were the 3 vectors for ventricular depolarization. In black, this was the 1 vector to show ventricular repolarization. What would your pen do if you used lead 1? If all you had to tell me was what would the pen do, go up or down, could you tell me what the pen would do for all 5 of these electrical events that I've drawn on the board? You can solve that by either doing vector analysis proper, which means, what would you do? You would draw your perpendicular bisector. That's what you would do first, right? I showed you that proper way. If I draw my perpendicular bisector, do you agree I've turned lead 1 into a number line with positive digits and negative? Do you agree? Do you agree that if I now deal with 4 quadrants, 2 of these 4 quadrants are positive side for lead 1, the arrowhead side? Agreed? And that 2 sides or 2 quadrants would be negative side of lead 1? If you don't like your perpendicular bisector, fine. Then use your close approximation. This electrical event, my moving animal, is the arrow pointing overall to any of the 2 sides that are positive for lead 1? It is. So what would your pen do? It's parallel. Pen would go up. How is this arrowhead pointing? Is it pointing to positive sides of lead 1? Pick it up. Pick it up. It's pointing to negative. That's anti-parallel. What would the pen do? Go down. What about this one? what would the pen do? Go up. What about this one? Look, this is still pointing to a positive quadrant. Pen would still be going up. What about this one? Up. Now you might be saying, Kara, how can the pen keep going up, 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 up? We're forgetting that after ventricular depolarization, all cells would have a negative surface charge. We're forgetting in between here and here, the pen would do what? Go back to baseline. You're going to take a break, and when you come back, I want your homework packet out. Sorry, lab manual out. So go have a 10-minute break and come back. 10-minute break? Is it already 10?
Yeah.
We go to lab.
I'm
I'm losing all track of time.
Spring break.
It's too many classes. Go have a 10-minute break, and when you come back, I want your lab manual out, please. And I need food after that. It was hard work.
That was
That was hard teaching.
like one thing that I just couldn't get, and I get it now.
That was hard work. Vector analysis, not easy.
Gotta mule over that a little bit longer.
Not easy stuff.
I don't know how to grab it here.
Weren't there. I know. I saw when it wasn't there.
Oh, okay, you want to